दिखाने के लिए।
आपका पीपीटी ओपन रखिए, मिनिमाइज
हाँ जी
इट
सर।
and then screen share. Now open it. Perfect. Perfect.
Sir, is it visible?
Yes, perfect.
Yes, it's visible.
Dr. Deva, you want to have a look?
Pankaj, sir.
Yes. Yes.
I
बोले
think
Dr. Samir.
we can have words of wisdom from Balavenkat sir.
Of course.
Before we
That's why I said
start.
before officially starting it, of course. Dr.
Yes.
Virendra is there, Dr. Bala is there. Both are happy to have both of them.
Yeah.
Deva, you want to screen share? Or we start the program?
Yes, sir. I am sharing, sir.
Okay.
Visible, sir?
Yeah.
Yeah, it's visible.
Perfect.
Yes.
Perfect. Dr. Kapil, you won't be able to do screen share for you? Unmute yourself, sir.
Yes, sir. Please.
Okay. Chalo, good evening. Welcome. We can start official. I feel it's live on YouTube also. I welcome all the practitioners in the country for yet another session or rather webinar on how we can improve the safety of anesthesia in the country. National ISA is very proud to be associated in increasing the safety awareness in all over the country. And this year, a lot of new steps have been taken by Dr. Bala Venkat and team. I hand over the to Dr. Bala Venkat and Dr. Virendra Sharma would like to speak a few words before we start the session. Dr. Bala Venkat, sir.
Thank you, Dr. Pankaj Gupta. Good evening to everyone. I wanted to heartily congratulate Dr. Pankaj for taking this initiative of conducting meetings very regularly with focus on anesthesiologists in the private sector. Because I think in this country, if every surgical patient needs a safe anesthesia, it's not been possible without the help of private practitioners. When you look at the world statistics, several countries in this world are not able to meet this challenge of the surgical load versus anesthesiologist, because the private practice, the way it has thrived in this country, is not present in several countries. So we're extremely thankful to all the private practitioners for their dedication and commitment in making sure that in whichever part of this country someone comes for a surgical procedure, there is an anesthesiologist available. So at the outset, I would wanted to congratulate each one of them for taking up this challenge of doing cases in peripheral units, possibly not having the best infrastructure on all the occasions. And hence it becomes important. Sessions like this will throw pearls of wisdom from several of our colleagues who have gone through certain challenging situations in their practice. And I'm very happy today, 4 excellent topics have been identified. And I think the first topic of Dr. Divya Gupta, pearls of communication skills for anesthesiologists, truly important, and it should start from the preoperative period. And the anesthesiologist, as a mandate, should speak to the patient and the patient attenders before giving anesthesia. In private practice, sometimes it may not be possible to go and see the patient the previous day, or they were informed of the surgery just about an hour before. But even then, I think they can meet the patient in the pre-op room, call the attendants, and then speak to them before actually inducing. I think this is very crucial and very important to establish the first connect. And second, if this connect is established very well, when you enter into the challenging situation, like what Dr. Kirandeep Singh Sandhu is going to speak, anesthesia and adverse human circumstances. So when the primary contact has happened and you know the face behind, it's very easy to communicate. So in adverse situation, when it happens, it becomes a big handicap if you have not seen the patient attendant before explaining an adverse event. And I think Dr. Jayal Alwani is going to speak. Ensuring anesthesia vigilance beyond traditional boundaries looks a very interesting topic. And also, I would like to thank Dr. Jayal Alwani for her excellent work in making sure that all the workshops of the forthcoming ISA Con Raipur is in place. And all the faculties have been decided. Everything is in the website. Very well done, Dr. Jaya. And please utilize this opportunity to invite and welcome all of them to this beautiful city of Raipur, and especially workshops which are completely designed to help all the private practitioners to enhance their skill sets. And this time we have, in every workshop, we have a course director from the ISA, and we have a course director from that particular specialty who does only that specialization. So this is going to be very unique, and I extend a warm welcome to all those who are present here to ISA Con Raipur. And anesthesiologist life beyond the mask is an excellent topic again by Dr. Kapil Singhal. Dr. Kapil, thank you so much for your contributions to the ISA, and you have done extremely well in propagating ISA in the state of Uttar Pradesh. So we have 4 excellent speakers, and I wanted to also congratulate Dr. Divya Gupta, the most proactive, energetic person who comes up with several ideas, including she wanted all of us to share a picture with a teacup. So she is pretty active. And Dr. Kirandeep Singh Sandhu, who has done phenomenal work in several facets of patient care, including cognitive dysfunction, delirium, and all. So we have a galaxy of excellent speakers to share their thoughts, and we are looking forward for a very, very fruitful, engaging, impactful session. Thank you so much for your contributions, and over to Dr. Pankaj Gupta, and also take this pleasure of welcoming all those private practitioners who come for this meeting, all the senior leaders, all the members of the National Governing Council members, and the state leadership of ISA and city leadership of ISA from across this country. Thank you so much. Over to Dr. Pankaj.
Thank you, Dr. Balavenkat, sir. You made my job very easy. I need not introduce all the galaxy of speakers that I have to. I'm sure Dr. Virendra Sharma would like to speak a few words before we start. Dr. Virendra? Unmute yourself.
Yeah. Good evening, respected President, Dr. Balavenkat sir, Dr. Pankaj, my colleagues in the Governing Council, past GC members, senior faculty members present, today's speakers, and my dear friends. First of all, I would like to thank and congratulate our President, sir. What I've been observing, I mean, with so many activities happening, Sunday morning and Sunday night, I could see him. So that is the sincerity and dedication to the job which is given. And if he is doing it sincerely, I expect that we all should take our job seriously. And with these webinars which are being arranged by Dr. Pankaj continuously, and we've been telling that, look, those days in 2017 when we revived the Private Practitioner Forum, things have moved ahead. Now it is almost 8 years. And these topics are specifically designed for you all. And everyone should try to attend. See, spare 1 hour, you are definitely going to learn these things. It is in day-to-day practice that these situations come. So I congratulate Dr. Pankaj for continuously planning and involving members from different parts of the country. It's a very good job being done by you. Congrats, Dr. Pankaj. And today's speakers, I know them personally well. I'm sure that they are going to present it very well. All the best to speakers, and thank you all the private practitioner who have joined. Thank you, sir.
And also, I want to thank Vice President Dr. Virendra Sharma for taking several initiatives for private practitioners. for several years now. I think that's been a wonderful gesture by
Thanks.
you. And also, not only that, you are making them very rich by making sure that they also do good financial planning. Two excellent things that you have been doing for years. Hearty congratulations for that
Thanks.
to Vice President Dr. Virendra Sharma, and over to Dr. Pankaj.
Thank you, sir. Thank you, sir, for the encouragement and the words of wisdom, which I feel all practitioners in the country are following and will continue to follow even in the future. Coming to today's topics, I feel communication is one of the most important thing, which is also one of the most neglected topics, especially in private practitioners. Many times I have seen patients just walking to the OT and just anesthetists walking to the OT and inducing the patient, which is definitely not what is safe. So we promote communication skills for the anesthesiologist with the relatives, with the patients, and also with the surgeons. It's very important today to communicate with all of them. Our first speaker today is Dr. Divya Gupta. She is a professor at the Himalayan Institute of Medical Sciences, Dehradun, Uttarakhand, which is also called the Land of Gods. She is a very active president, as Dr. Balavenkat rightly mentioned. She loves her pediatric anesthesia and simulation and communication skills. And I feel one of the things which she really speaks very well about. Over to you, Dr. Gupta, Divya Gupta, madam. Let's start screen sharing.
Thank you, sir. Respected President, sir, Balavenkat, sir, respected Vice President, sir, Virendra Sharma, sir, Pankaj, sir, other GC ISA national members, and all the listeners. I welcome you all. Thank you at the outset. Is my screen visible, sir?
Yes, madam. Just make it full screen.
Yes, sir.
Perfect.
Yes, sir. So, the topic given to me is pearls of communication skills for the anesthesiologist. As Sir rightly said, it's very close to my heart. So, to begin with, I bring greetings from Devbhumi, Uttarakhand, the land of gods. And this is my institute, Himalayan Institute of Medical Sciences. Of all the life skills available to us, communication is perhaps the most empowering, in the words of Brett Morrison. So it is derived from the Latin word communicare, meaning to share, to be in relation with, to impart and participate, broadly meaning the transfer of information. So it is defined as transferring information to produce greater understanding, in which the messenger gives a message in whatever channel which is available, like speaking, writing, graphics, or video, and the recipient receives it, and there is a change in behavior and whatever the understanding is. So there are few types of communication which have been designated, like verbal communication, as we are doing, which is done vocally through verbal exchanges, written communication through written media, by books, websites, magazines, and documentation, as in due course of my talk I will be sharing. Non-verbal communication, which seems to be unimportant, but it makes more than 94% of the communication which we do, in the form of body language, the gestures, our voice tone. Visual communication, be it in form of charts, graphs, cards, or more commonly in our area like VAS score and NRS score. So we, the anesthesiologists, the perioperative physicians, we are dealing in a specialty where we need to be vigilant with prompt decision making and quick actions. But still, the public at large is not aware of the anesthesia, the risk involved in anesthesia. Why is it so? It is because of the limited scope for interaction between patient, their families, and us, and hence there is the paucity of rapport. As Sir rightly said, we have limited contact times. The first time we see the patient in PAC clinic, but in the private practice, mostly they land up in the OT directly, or we meet them in the preoperative area the day before surgery, or in the intraoperative period and the postoperative period when the patient is recovering from the anesthesia. So we have these limited contact times, and during that time only we have to deal with them. With our good communication skills only we can make a rapport with them. So these are the 7 C's of communication, how we can handle them properly and make them clear, concise, concrete, correct, coherent, complete, and courteous information. We should tell them meticulously all the things which are relevant to anesthesia so as to deal with their apprehension. So, patient interaction, the first thing the patient comes to us. So, we should have a shared beliefs. We should handle the patient compassionately. They should have that feeling that we are present for them, a mutual understanding, a respect, knowledge sharing, and experience. The patient will develop confidence in us. There should be a personal chemistry, honesty, and integrity in the which we have with the patient and the relatives, which will build in trust and confidentiality between us and will smoothen the course of anesthesia. Team coordination, nothing happens alone. We in anesthesia also, if we are handling a case, we have a team of a faculty, a resident, OT technician, staff. So for smooth anesthesia care, we need proper team coordination which is built on good communication skills. A most important aspect, the risk communication. The residents who might be listening to this talk, they should be very, very cautious in dealing with this risk communication and they should never ever explain this risk alone. They should explain it in front of the surgeons, otherwise, they might be blamed later that how the risk has been explained, what the risk has been explained. So, we have to be very meticulous in informing the risk. Another area is structured handover protocols. We give anesthesia, the patient is shifted to the recovery, but the staff or the deputy resident or any support system, he or she is not aware what type of anesthesia has been given, what needs to be given further, what fluid needs to be given. There should be proper taking handing over. Dealing with emergencies, my friend Dr. Kiran will be handling later. At workplace emergencies, natural disaster, medical emergency, for example, we land up in difficult airway or in a laryngospasm. The first thing is we call for help. Again, a major building block for good communication. If we don't call for help, how will we handle the situation? Be it power outrages, fires, explosion, there are audio visual communication in the form of alarms. So these all are also dependent on communication. So we should adapt to the change. Increasing flexibility and adaptability skills in the workplace is very, very important. Why? So that we can avoid this burnout syndrome, which is commonly prevalent amongst us and other physicians as well. As we are dealing not only in the OR, but also we are expanding our horizons in the ER, in the ICU, in the NORA, pain clinics, palliative clinics, medical education, even in the leadership roles and administrators. So, everywhere there is the communication, which is the most important aspect. Another evolving role amongst us is community outreach. That is, we are building bridges of hope. How can we handle the math of the patient might be thinking that I will not take spinal anesthesia because I might as well get backache because they have had that from a word of mouth from their neighbors. So we have to outreach them. We have to come in contact with them. Then only with good communication we can break those barriers. So we are having this multi-cadre role. We are handling with patients and attendants, peers and colleagues, team, surgeons, nursing staff, being a multidisciplinary branch, even the students. So everywhere it is the good communication skills which will lead to good interaction. Another mandatory arena where the anesthesiologists are the leaders is giving CPR. In that, closed loop communication is the building block where the sender initiates the message, the receiver receives it and does it and confirms that it has been done. So, effective communication, the patient will never care how much you know until they know how much you care, in the words of Terry Canel. So, the art of anesthesia is reliant on professionalism, and significant part of that is communication. So we, with effective interpersonal and communication skills, can preempt medical disasters, expensive interventions, and ensure provision of better patient support. Just look at this picture. The patient, when we are handling him in the PAC area, in the first look, the patient will feel where I have got stuck, what I will get. I will get regional, general, local. What will happen to me? Will I be relieved of my pain? So, the key to success and to their queries and anxiety is communication, good documentation, communication of documentation, and documentation of communication. If we communicate, we do not document, nobody can save us. If we document, but we do not communicate, then the patient is totally unaware. So we must tell the patient and the attendants as well about the concerns of regional, general, monitored anesthesia care, local anesthesia, whatever may be the course of anesthesia, and specifically the preoperative order should be very, very clear.
The reception.
The consent in anesthesia. My talk will be incomplete until and unless I talk about words about it.
दुकान
Excuse me.
जाने चलो मुझे
Obtaining consent. Consent is a process during which we provide adequate and accurate information regarding anesthesia to a patient, which makes the course of anesthesia smooth and comfortable. It can be written, verbal, or implied, where there is shared decision making, respect for individual integrity in his or her own language, disclosure of risks and benefits, and the patient is allowed to ask questions and the patient will get the answers as well. Documentation, as I told, it is invaluable and essential form of written communication at multiple levels. It safeguards not only the patients but primarily us also, because nothing can be proven in the court of law if it is not documented. Good documentation is good defense, poor documentation is poor defense, and no documentation is no defense. Coming on to breaking bad news, there also our communication skill can make the patient or the patient's attendant accept that bad news. Your warmth, your compassion, your
सबसे
empathy
मिला दो ना
will help him or her
इतना
accept.
उल्टा आ गया
Again, handling an angry patient. Patient is in a fray. Patient is in a suffering. We have
चलो
to handle
जल्दी
patient very cautiously by our meticulous communication skill. So, our vision is that good communication is as important to protecting professional integrity as it is to patient safety and satisfaction. So, seeing the need of the hour, recognizing its importance, the American Society of Anesthesiologists has charged the Committee on Communication to improve public education as it relates to anesthesiology. The communication is the human connection which is key to personal and professional success, in the words of Paul J. Mayer. So, our mission is to communicate effectively, as good communication skills are the key to success. Thank you so much.
Excellent talk, madam. Exactly what I wanted to convey to all the practitioners. It was very effective communication of what you wanted to communicate with all the communities, that is the anesthesiologist and the patient. Just excellent. Just to add one or two things, I feel one
Yes.
important thing is your non-verbal communication, especially in the operation theater with the
Yes, sir.
surgeon, is as important. The moment a surgeon feels that the anesthesiologist is not confident, believe me,
Yes.
I know of an incident where it happened that the patient unfortunately arrested after giving spinal.
Oh.
And along with the patient, even the anesthesiologist collapsed in the operation theater. Fortunately, the surgeon was well versed and he could resuscitate first the anesthetist and then the patient. So this sort of thing should never happen. Unfortunately, in private practice, we are all alone. It's a one-man show, so your confidence level has to be very, very good. Also, regarding the 7 C's was just perfect, madam. And of course, regarding PAC, many times it happens we are unable to see the patient preoperatively. Now the law says that according to the law of telemedicine, if you cannot visit the patient, you can definitely use telemedicine, make a video call to the patient, try to interact with the patient and communicate. At the same time, even while entering the operation, they do look for the relatives. If you can talk to them, definitely it makes a lot of sense. that what you plan and what you don't plan. Thank you, madam.
Yes, sir.
That was really, really a very thought-provoking and very nice lecture. Thank you, ma'am.
Thank you, sir. Thank you.
Our next speaker is Dr. Kirandeep Sandhu, who is the head of department at the KIMS Hospital in Nasik. He's an astute speaker, makes difficult topics look so simple. She is very forthright and outright in her approach. We call her our smiling lady of Nasik. We have to really see her quotes which she shares on the groups. Anesthesia and adverse human circumstances is a very far-fetched and a very difficult topic to speak on, and I'm sure she'll make the best out of it. Over to you, Dr. Kiran. You can start screen sharing.
Yes, sir. So while I share screen, I would actually want to ask everyone, what do you think is DCP? Okay. Someone may think it is a 2 crore bonus by Pankaj Gupta sir for attending this webinar, double for speakers, or is it like Daru with cute buddies or something? But what do you think is DCP? Now, having said that, it's something that's not foreign as a subject. It's something that is actually a very core essence topic that we all need to say. Sir, my screens are visible? Yes.
Yes.
So as much as we would like to believe it to be a 2 crore bonus, but DCP is actually a clinical term that is not so familiar in Indian scenarios, but in last 15 years, US, UK, and a lot of Western worlds are trying to do a lot of work. So it basically means disruptive clinical behavior, disruptive clinicians. So when we are talking about working, whether we work in a medical college sectors, on a corporate sector, or we work as a private practitioner, all of us are flag bearers of our professions, right? And so, as I said, how good or professional we are to each other and how we are on the other spectrum. So let's, without wasting any time, I would just start with the presentation and go with the terminologies which have been there, sir. So, can you see my?
Yes, you can.
Okay. I seem to be stuck on this. Okay.
Yes.
So what do you think is disruptive? Now, disruptive behavior, when we have been in healthcare sectors, it's behavior by our seniors. Those surgeons are the most common instigators, but disruptive behavior is something which is exhibited across the entire spectrums. And it's nurses, it's technicians, it's administrators. And we as anesthesiologists have also been witness, perpetuators, as well as victim of this. And as a norm, we have ignored it, we have accepted it, we have expected it, we have enabled it, we have tolerated it, and certainly underreported it. But going forward, in 1995, the disruptive physician term was coined by Weltman, and 2000, for last 15 years, if you look at the body of work, Rosenstein is the one who has worked any inappropriate behavior, confrontation, conflict, which is from verbal abuse, from intimidation, berating, disrespectful, or abusive, to physical or outright harassment. If we look at the words, Presovich described 207 different words, from incivility to bullying to harassment. And JCI recognized, that is the Joint Commission, this is not a behavior we as a responsible healthcare can ignore. And they gave it a status of this disrespectful behavior to each other as clinician as a sentinel event. So it is at par of mismatched blood transfusion. It is at par of wrong surgical site. So a behavior that we exhibit is put, if it's disrespectful, given that status into there. So in the last 10 years, let's look up what the studies. When I went across all the studies, there are very few which we come across when we look up at our Indian scenario. Most of these, except one or two, are from Indian scenarios. When we look at disruptive behavior, now this could be frank, outright aggressive behavior, from yelling, foul language, threatening gestures, insult, intimidation, invading, slamming down our space, being physical aggressive. And unfortunately, we have been witness to these, and mostly by surgeons, but many times by non-surgeons too. But more harmful or equally harmful is the passive aggressive behavior, the cold shoulder, hostility, intentional miscommunication, condescending language. Ma'am talk about communication, how we sir rightly pointed out our body level, malicious gossip, jokes which were inappropriate, sarcasm, implied threats, especially retribution for making any complaints. So, but it's also important to know what is not a disruptive behavior. A good faith criticism is not disruptive. We all have a difference of opinion. As long as it is done in the boundaries of civility, yes, we can definitely appoint it there. And giving even testimonials and stuff is absolutely valid. Now, how common is this disruptive behavior? Most of the clinicians are professional. 90% would be in professional and 10%. We don't have a genuine data. We have never actually put ourselves out for survey. Last year, there was a beautiful questionnaire which was put up, but that was focusing on surgeons' behavior. I think it's equally important to behave on our behavior as well first. The ubiquity is around 6 to 18%. The alarming thing is that 97% of us have at a point witness disruptive behavior. Incivility was 70%, frank right outpulling was around 36%. Now, these are some of the studies. Obviously, we don't have the time, but if we look up at the one of the latest one, the 2021, 22, where we have about 7,000 to 20,000 groups in which we have taken anesthesia, on an average, an anesthesiologist respondent would have anywhere from 6 to 62 times. It's not that you have experienced disruptive clinical behavior once or twice. It's in a very large number, which is averaging around 30 to 40 times in an year annually. So that definitely is an alarming figure. If we look at gender distribution, it's more or less similar to both, but it's more of seniority versus, and poor residents are probably the one who get the worst deal, as we all probably have gone through our stages we were studying into there. From failing to respond, excluding from decision making, blaming, dismissing, yelling, disintegrating. So some of the behaviors that we pass on to each other. So definitely, what do they cause? Stress, number one, they cause frustration. And this is when we look at objective perception, what they're causing. 95% felt that it led to frustration, it led to loss of concentration. It definitely leads to reduced collaboration, reduced information transformation, and adverse effect, from errors to patient safety to quality to patient mortality. Obviously, if a surgeon is being rude to me, I am not inclined to be extremely bright. That's what happens when we are in a team. And if we look at the reason when most of the adverse effects or the sentinel events which have caused potential harm to the person, number one is human factors, and in number three is that communications. Most of the avoidable, preventable errors are related to communications and human errors, and disruptive clinical behavior contributes hugely into those scenarios where this is happening. Now let's look up. We are working in a stressful environment. We may be sleep deprived. There is body issues. There's so many different interplays which are happening. So there is a trigger. Now, at that trigger, there is always a negative emotion which is generated. At that point, a clinician could choose to control it, or it could go into a disruptive clinical behavior. Now, what happens is, it is not a simple thing, like somebody didn't do the behavior as expected. In an environment, it's what were your interpersonal relationship with those, what were the communication skill, what were the technical, what was the scenario background in which that interaction took place. Was the working environment a stressful environment? If your infrastructure doesn't have the adequate resources, which adds on to the pressure when you are working, what is the organizational culture? What was the pressure in which the patient was losing life? So all of those scenarios, and we end up having a scenarios. Now, when we have a response, whether it's incivility or microaggression or bullying or harassment in a work environment, you could either ignore it, you could deflect it, you could confront it, or you could enlist it. Irrespective of, unfortunately, either of the four components, it's still going to affect you psychologically, because when you ignore it, you are just making it perpetuate. If you confront it, there's always a fear of either retaliation from a bully or from an organization, which sets you back forwards. And especially in private scenario, I can imagine where you are working alone. That's where a body like Indian Society of Anesthesia has a huge pivotal role to play, to support its anesthesiologists so they get treated professionally. But when I say that somebody needs to treat us professionally with respect and dignity, the onus is also on us to carry ourselves with equal respect and dignity, and treating our juniors, our staff, our nurses, our RM, whosoever we are coming in contact with, the same respect that we expect for ourselves. Now, these interactions cause huge additional. So on an average, they found out if it's a 200-bedded hospital in US, incivility and disruptive clinical cost about a $1 million US. We fail to understand the impact of this behavior. Besides the emotional toil, it actually adds on to financial losses too. So now the question is, we have deep-seated pressures, we have situational. Situational could be an angry, hungry, not well, sleep-deprived person who's responding in a scenario who's otherwise calm. It could be a provoked confrontation where the surgeon or the whosoever is the instigator is being unreasonable. Is deep-seated. Your medical training, what kind of mentors you had, what role models were there, and you expect it as normals, and your experiences and the environmental pressure. And here there is a vicious cycle. Stress leads to disruptive clinical behavior, and that causes more stress. Same way with fatigue, burnout, depression, substance abuse, or even outright illnesses. And the clinicians who exhibit this thing, and especially the US data, they found out that those people than one clinical diagnosis. In fact, 78% had XS1 diagnosis from depression, alcoholism, bipolar, and anxiety disorder, adjustment disorders. The point is, many of these maladaptive states are treatable. Problem is, we don't ask for help and we think of this as a normality. ऐसा है, ऐसा चलता आया है. So that's the point. This entire awareness in last 10 years has been that these behaviors are no longer considered as normal behavior. So we have now started looking up at chains in disruptive. How do we cognitively assess ourselves when we are about to do these? What are the impact on the students who are coming to us? What are the impact on the clinician? And what are the impact on you as a whole? There are a lot of responses in this, from manipulative, avoiding, promoting. I don't have the time to take clearly into these accounts, so I'm just brushing over them, basically giving a framework. We need to set the standards of clinical behavior from ourselves as professionals, as torchbearers for our specialties, whatever interactions we have with our patients, with their attendants, with our pharmaceutical partners, with our surgeons, with our other colleagues, juniors. It has to be in the civility parameters. We deserve to treat them there. We need to equip to meet the standards. There are a lot of training workshops on anger management, conflict management, tools in communication, awareness things that we so far didn't put it as a curriculum of, and I hats off to ISC and Pankaj Gupta for taking these topics, because they are not something we consider as part of core medical curriculum, but they are essential as our professional. And it's important to monitor the compliance with standards. And wherever there are deviations, we need to put them into actions, and there are ways to do that. The good thing, as we said, most of the professionals do not want to be unprofessional. Generally, it's one off an occasion. But if we have clinical champions in a corporate structure, it could be just there. In a society, in a group, there are always seniors that people listen to, adhere to, who can go back and tell people, look, this is a behavior which is not the gold standards. We need to, sometimes just the awareness will do there. But if this is a pattern of there has to be a zero tolerance for this kind of demeanor and bad behavior. there are multiple conflict risks. Like if you go back there, hey, I thought you were very harsh when you spoke to that resident, and express their behavior and the impact it would have, suggest a different alternative, and also tell the consequences that result from this behavior in the future. The any disruptive behavior, when you are doing there's always an analysis. Who is it affecting? What is the cause? What are the systemic failures? Why either we are not identifying it, or we are not responding to it, or we are tolerating it? What are the practical strategies that we can put into place? Because each setup is going to be different. Private sector has additional challenges as compared to a normal sector, even those sectors there. Once we have put the analysis of us as clinicians, we have to look up at target organization, at satellite organization, and as such as a total healthcare package, which clearly says we are zero tolerant to this kind of a behavior. We treat each other with civility that is required. And so that overall an entire hub, a cultural change can. If we look at 10 commandments they give at an organizational, at the top level, it's a leadership commitment that we are professionals, we will behave like professionals, and we will have an internal introspection, what we need to do, whether it's in our curriculum in training programs or where we work there. And having clinical champions, they're similar to mentors who can actually help soothe down the situation and lay the foundation. Structured educational, where the diversity, sensitivity, conflict management, etiquettes, how we need to be. It's amazing that by the time we finish our training, half of our etiquettes are literally thrown into the bin. Communication and collaborative relationship building with our colleagues, from policies and procedures and intervention. In interventions, we are talking preventive, we are talking real time when it actually takes place, and retrospective and how we put into those criteria. Important question to ask ourselves is, am I a perpetuator of disruptive clinical behavior? Or am I a witness to disruptive clinical? Or am I a victim of there? Neither of them is a good state. We might have been all three at one point or the other. Now, what to do if you are a witness? Speak up. Now, if you just blindly ignore disruptive clinical behavior, you are as culpable as the person who's propagating. You do confront the behavior, support and advocate for a colleague who you see is being bullied or receiving on there, refuse to participate in rumors and gossip, and challenge that's just the way who they are, that's just the way. You document the behavior and report it appropriately in time. So you can't be just a silent witness when one of your colleagues. So once we see any of our colleague who's slipping on the wellness spectrum on the negative side, it's our responsibility to care for them also. When we look up, when you are faced as a victim, first and foremost thing is to remain composed, stay dignified, directly address the issue and set clear expectation. Use assertive, polite, clear language and communicate the boundaries which are being there. At the same time, help them understand the impact of their actions. Sometimes they may not be, and do offer an opportunity to improve. So if it's a surgeon colleague who doesn't understand, it's not that you go on Cold War and we start sending drones to their hospital. We definitely give them a chance to improve. And what if we are the one who are about to trigger this behavior? As clinicians, sometimes we are unaware of the impact, and this amygdala hijack takes place. Take a deep breath, label the emotion that you have, put yourself in other person's shoes, and be mindful of changing landscape of medicine and current expectations of behavior and emotional intelligence that people expect us to have. So there are a lot of good work which is happening. John Hopkins has got this rules of civility that it puts to the people who are coming in there. There is their first and foremost thing as anesthesiologist, I think, is respectfully asserting ourselves is the core fundamental. This most of us tend to. It's important to respect yourself. It's important to respect your colleagues, respect others' opinion, time, space, acknowledge their worth and effort. Don't blame and just keep it down. Similarly, Ontario says, be aware, communicate effectively, take good care of yourself, and be responsible. It's a wide spectrum. I will stick to my time, and I'll just say this is a great initiative, a great conversation to start. or do we start getting more professional? Thank you so much for the opportunity, sir. Thank you.
Dr. Kiran, I feel this talk could not be better. When I discussed this topic with her, I was a little skeptical, what what she had in mind. After listening, I realized that I have been a witness, I've been a victim to this sort of behavior in the operation theater. And all of us take our own way how to handle the situation that we are in. I feel being a private practitioner, one very big decision that I had taken very early in my life, where I found a surgeon who was very disruptive. I just stopped. I could easily say no. But this is not the same situation in corporate setups or in other setups. I'm sure you'll have a lot of questions at the end of the session, Dr. Kiran. So please be in line and we'll continue with the next topic now. Our next speaker is Dr. Jaya Lalwani. She's from the Pandit JJM Medical College, Raipur. She's a writer par excellence, has innumerable publications and chapters in books. She is a recognized course faculty and trainer for COLS, BCLS, and other such CCLS. She has done a good work on public awareness regarding resuscitation, obstetric anesthesia, labor anesthesia, and is a well-known faculty all over the country. Last year, she also received the ISA Proficiency Award from ISA. Over to you, Dr. Jaya.
Thank you, sir.
Please.
Thank you for the kind words. Till I start sharing my presentation, a very good evening to all respected members, GC Council members, my seniors and friends. Just a minute.
Till you screen share, I mean, the topic that we had discussed were from suit to site, ensuring anesthesia vigilance beyond traditional boundaries. I feel as anesthesiologists, we have become not just preoperative physicians, we have made our presence felt in various other circles also. So I feel it's very important to know your limits, know where to give anesthesia outside the operation theater. Be careful about because the law has gone a little against what we have been doing in the last so many years. Now you have to be very careful where you're giving anesthesia, especially in MRI suits or CT scan centers. See that you have a proper backup. See that you have a proper access to a intensive care. There was some law laid out in some cities that if you don't have a ICU backup for these sort of centers, please do not give general anesthesia to such patients. So that's why it's very important to be very careful about what you are going to be doing outside the
Sir, is my
operation
screen
theater.
visible?
No, not yet, ma'am. You must have minimized it and you can start screen sharing now.
Select.
Actually, unfortunately, you are the only one who did not send me the PPT.
Sir, I have sent you on mail. I have shared,
Okay.
sent on mail, sir.
This must be very recent then, just before starting. Let me just check.
Sir, that is the reason I have sent the PPT to you, that we as
Exactly.
anesthesiologists are struggling many a times. We are not as tech savvy.
Okay, I can see. Yes, she sent me just at 6 o'clock after the program started. Let
It
me
is
see.
not visible.
No. Dr. Pankaj, can you make it? Screen sharing.
Yeah, I'm just trying to see if I can do that. Can you do it, madam, or no?
No, I'm not yet.
Okay, let me see.
Yeah, now double click.
Yeah, I'm finding the old this one.
Dr. Pankaj,
Yeah,
can we allow the next speaker to continue? In the meantime, you try from your email
yeah, that's a good
so
idea.
that our time is saved. Now.
Yeah, that's a good idea. Yeah. Madam, we'll start the next.
Okay, okay, sir. Okay. Okay.
Yeah, you can see the Kapil Singhal, sir.
Yes, sir.
You can see the screen, right?
Yes, sir. I will
Well,
try to share myself.
so I've already started. Can you
Okay,
see?
you have started.
No,
Okay.
your screen is not visible.
Okay, I stopped sharing. No?
Dr. Kapil, you are also co-host. Please share your screen. You try.
Hey, I've done it.
Yeah, it's
Right,
not.
sir?
Right.
Okay.
Right, sir?
Yes, sir.
Great. Till Dr. Jayalalani gets over this issue, I invite Dr. Kapil Singhal, an eminent anesthesiologist from Noida. 25 years he's been managing anesthesia and critical care. Right now he's working as the Deputy Medical Director and Head of Department at the Metro Hospital and Art Institute in Noida. As the President of ISA UP, he's been doing wonderful work, which we have witnessed many a times. And I feel I've attended at least two CMEs that he had organized in Noida. Very recently, in February, he organized a National Open ISA Cricket League, which was a very great feather in his cap, because it was the first time that we could have such a national sports meet. So that's why I thought of giving him this topic. That we keep, as anesthesiologists, we are busy in the operation theaters, ICUs, and it is anesthesia, and our life ends there. But I believe that all of us have much more than anesthesia that should be there in our minds and life. So over to you, Dr. Kapil Singhal. I hope you can throw light on what, other than anesthesia, we can do outside the operation theater and beyond the mask. Thank you. Go ahead, sir, please.
Uh, First of all, good evening to National President, Dr. Bala Venkat, sir, National Vice President, Dr. Virendra Sharma, and all other National TC members, my fellow speakers, and all the listeners. And I would like to convey my sincere thanks to Dr. Pankaj Gupta and National ISA for giving me this opportunity. And as Dr. Pankaj just mentioned, that anesthesiologists, we are confined to operation theaters, to the limit of ICUs and other indoor arenas. But there is much more life beyond the confinements of mass. So we are not just perioperative limited to anesthesiology is just not limited to perioperative care. There is much more beyond that, and their role is expanding in not only healthcare but also in many other areas. Anesthesiologists, they are expanding their roles as pain physicians, as hospital owners. They are wonderful administrators and they are entrepreneurs. There are many other fields where anesthesiologists are doing wonders and we can do wonders. Though anesthesiology as such is very challenging, full of challenges, but yes, there are few rewards. One of the few I would like to mention is, no sir, please, the previous slide only, that early settlement is one of the big benefit with anesthesia branch. And it is one of the branches where plenty of options in the and not only as anesthesiologists but as intensivists, pain physicians, and other field are available. But another flip side is that our branch is a high stress branch, and anesthesiologists are the ones who are suffering with high incidence of burnout rates. But there is still plethora of medical and non-medical opportunities. And through my talk, I would like to take through my fellow anesthesiologists to different medical and non-medical opportunities where we can indulge into. So sir, next slide, please. If I talk about the evolution of anesthesia, it from 2020 BC till date, it looks like 2020 BC was the era of pig anesthesia. where four strong people used to hold the patient and surgeon used to operate in severe pain. And with the advent of ether anesthesia in 1846, the scenario changed. And now we are in 2025 with the latest technologies, workstation and everything. And future is like, it may be a robotic anesthesia where a human interface not be required at all. Next, sir. So if I talk about a typical life of an anesthesiologist, where anesthesia people are thought to be working either in operation theaters or intensive care units, our day usually starts early in the morning, right? Like 6:30, and when we reach hospital, it's around 7:38, depending upon the kind of practice we are into. And significant percentage of time is spent in paperwork and administrative work, preoperative preparation of the surgical of the patients. Then we are conducting 2 or 3 surgeries a day, hardly finding a time to have lunch or tea or whatever. And by the time we reach home, we are exhausted, we are tired, and there is hardly any time which is left for personal well-being or to spend with family and kids. So that is a typical life of any anesthesiologist who are working, whether they are working in private practice or government setups or institutional setups. Next. So, because of this stressful environment and a tight, busy schedule, anesthesiologists are the ones who are stressed and suffering from more than one mental diseases. And the cause of high incidence of stress is not only long working hours. We are working indoors without any sunlight. We are handling critical patients. So many a times the person who are being anesthetized are having different comorbid conditions, and so most of our surgical colleagues, they will tell the patient attendant, see, my work is to the surgery, but the patient will be taken care by the anesthesiologist. So stress of handling high risk patient is another stress. And then last but not the least, many a times remuneration is also a risk factor which leads to a stress. So next, please. So this is a slide which I have taken from Anesthesia Journal, which is published in 2020, where around 44,000 anesthesiologists responded about the burnout in anesthesia. And there is around 60% incidence of emotional exhaustion or depersonalization, and they are at high risk of burnout. While around 14%, they met criteria for burnout syndrome, and they were emotionally exhausted, depersonalized, and having low sense of personal accomplishment. So this is a very high incidence. And the main cause which was found was that they are having perceived lack of support at work, not only at work, while those who are suffering with burnout syndrome, they were having perceived lack of support at home also. So these were the significant key factors, and other factors were working for long hours, and LGBT status, staff shortage, lack of support in work life, and other things were the key factors which were responsible. Next, sir. So another, this is a newspaper article published recently in Times of India, and this is taken from the International Journal of Environment, that working for more than 55 hours per week lead to nearly 750,000 deaths per year. So just by working long hours, we are rendering us prone for higher incidence of mortality. Next, sir. Not only this, but another study which I have taken is that incidence of suicides among the different medical professionals. And here all of you can see the incidence of suicide is much more higher among anesthesiologists. And if we compare it with the next medical fraternity, which is surgery, it is more than twice the rate. So that is the that simply shows that how much stressed anesthesiologists are. Next, sir. So now I've spoken about the different impacts which high stressful environment of anesthesia work has given to all of us. What is needed to be done? It has to be a multi-pronged strategy, but key is areas where we can work upon are first and the foremost is the professional area, where we can improve by our working by having structured working hours, team practice in another way to improve our working conditions, and then we can explore different career options. Even attending conferences as a delegate gives it provides an environment of lot of stress buster, and I would say that each and every one of us should try to attend few conferences a year. That gives us an opportunity to meet our friends, colleagues, seniors, juniors, everyone, and also to make new friends. Then the next point which I would like to stress upon is the financial area. Having additional income source is one of the key areas where we can work upon. Alternative careers, many alternative career opportunities are there. I'm going to share it with you. Early and the right investment habits. So mind it, not only early. First of all, all of us must start investing early in life, and that too with the right habits. Coming to the personal changes, what we can bring about is that well-being programs must be attended, must be adhered to, peer support, indulging in hobbies, be it sports, music, dance, writing, painting, etc. And again, organizing. Here I will say organizing conferencing, organizing different type of events is also stress buster, and it gives an opportunity to develop ourselves. Next. So first of all, anesthesiologists, their horizon is expanding professionally. It's much more beyond OT. The role has evolved to include not only perioperative care, but pain management, critical care. We are the leaders as far as resuscitation is considered. And we are not only the providers, we are also the trainers. By indulging in training of calls or CPR in any ways, whatever we can do. So we not only help the society as such, but we also tell public about the anesthesia fraternity, and it gives an opportunity for the public to know what anesthesiologists can do beyond the operation theaters. Career can be expanded by indulging in academia, telemedicine, intensive care, palliative care, and not only these, but healthcare innovations as well. We can also mitigate our burnout, and because of that, we are exploring diversified roles by blending clinical, academic, and many entrepreneurial pursuits. Next. So just to quote a few medical opportunities, medical career options which are available to anesthesiologists. First and the foremost, all of us knows that pain management anesthesiologists are rapidly indulging in as a pain specialist. We are not only practicing in corporate setups or hospital setups, but many of us, they are opening their own setups, and they are doing wonderfully well. Anesthesiologists, by virtue of their training in handling emergencies, they are the key leaders in emergency team, trauma team, rapid response units, and resuscitation units. And also, they are actively involved in pre and post operative optimization, ERAS protocols, rehabilitation, and another recovery plannings. So next, please. So teaching and mentorship is another area where many of the anesthesiologists, I know one of the anesthesiologists who has left his practice. He is just earning by virtue of teaching. He is giving classes to another medical professional. Those classes involved reading X-rays, reading ultrasonographies, reading ECGs, and all those things. So that is another entrepreneurship which one can develop. And engaging in any DNP programs, clinical rounds, and structured resident teaching are also areas where anesthesiologists are involved. Coming to CME and conferences, definitely they help. Not they are two ways. This is something which helps in dual ways. It helps in our personal development as well as it helps by sharing our knowledge, by sharing our expertise, we benefit others also. Then anesthesiologists can indulge in research and innovations. We can pursue in clinical trials, institutional projects, and publishing in peer reviews and anesthesiologist journals. So next. Now, this is another area by virtue of our deep knowledge of different surgeries, by virtue of our role in intensive care units, anesthesia is one fraternity which have vast knowledge of almost all the medical subjects. And they have proven to be a very good consultants and they are working as a consultant not only with hospitals, but with startups, health technical firms, and they also help in designing various protocols, analytics, and quality controls. And it is a very well-known fact that anesthesiologists are doing wonderfully when it comes to playing roles as administrators, and they are holding key administrative positions in various hospitals. So another opportunity is that collaborating with the medical industry, which are developing devices, and we can collaborate in product development, safety testing, and clinical validation for anesthesia tools. Now coming to entrepreneurship. There are various and vast areas where anesthesiologists can definitely launch their products, and launching ventures not only digital health, education platforms, wellness programs, owning healthcare setups. Many anesthesiologists, they are running their own hospital setups. They have developed pharma setups. I know one anesthesiologist who has established her own pharma setups, and he is manufacturing anesthesia medications. Medical innovations is another area. Even our ISA National has recognized ISA members who are doing good in medical innovations. And then development of equipments, etc., is the another area where we can work upon. So next. So next, I will come to financial growth. So, apart from our routine career opportunities, we must have to look for different source of incomes. So this can be created by selling online medical courses, lectures, and as I said early, that early and the right investment is the key to success. Each and every anesthesiologist should start investing, and the area of investment can be different. It has to be diversified. It cannot be, we must not put all our eggs in one basket, as it is said famously. And by virtue of our lesser understanding of financial systems, we must try to seek professional help. We must sit with financial advisors, if not once a month, at least quarterly or half yearly. Setting up our own industry or startup is another area where we can look upon. I met an anesthesiologist who has started a setup with startup. They are manufacturing scrubs and scrub caps, and they are beautifully designed scrub caps. Recently, I met that anesthesiologist, and she's a young anesthesiologist. I met her in Hyderabad during National YuvaCon. So now developing, investing in AI is another area which is related to anesthesiologists. Next, sir. So I will quote a famous quote from one of the most famous investor and richest investor from the world, that if your salary is your only source of income, you are one step away from poverty. So have at least one or two other source of income. And I would like to quote another quote from him, that he said in an interview that he feels he started investing at the age of 14, and he feels today that he started late. So all of us must start investing wherever we are. Next slide, please. Now coming to the personal well-being, which is one of the most important aspect of our life, and it is not a luxury anymore. It is more than often neglected by all of us. we are busy with our schedules and neglecting not only ourselves but our family also. So first and the foremost, I would like to say that each and every one of us should prioritize our personal life. We must give some family time and personal time. So I asked today one of my orthopedic colleague, what is your priority in life in day-to-day practice? He said, sir, I would like to give at least 1 hour a day for my personal fitness and at least 1 to 2 hours a day to spend with my kids. So please, all of us should start spending time with family. It may be on the daily basis, it may be and then having a regular family vacations that really helps us to come out of the stressful zone of work which we are there. Coming next to mindfulness and daily reflection, regular meditation, breathing practices, journaling, they promote resilience and emotional clarity. So we have to indulge in certain type of spiritual or mindfulness activity. Then indulging in any physical activity like yoga, somebody would like to have daily walk, daily run, playing tennis, playing cricket, whatever. So, but each and every one of us must find time to indulge at least in one or other physical activity. That only not helps in enduring, not only helps in physical endurance, but it also helps in giving a positive energy to the mind. And that in turn helps us to keep focused. So it is very important to indulge in regular physical activities. And sleep cycle, keeping a sleep discipline of sleep cycle is also very important, and it helps us in reducing the fatigue and helps us in getting energized. Next slide. Now, we have to look beyond operation theaters. As Dr. Pankaj mentioned, we can really indulge in various organizing various events. Dr. Pankaj, I know he himself organized at least n number of national or state level events, right from chess tournaments. He has been a support to the car rallies, to motorcycle rallies, all those things. As he mentioned, recently we have organized a national level cricket tournament at Noida, and 200 anesthesiologists from all across the country, along with their family and kids, they participated in tournament, and it not only helped in exploring in giving an opportunity to show our hidden talents, but also it was an opportunity to make new friends, to really explore ourselves. And I must say that organizing tournaments or events is another way where we can really de-stress ourselves. Then it also helps social cohesion and belonging. Non-clinical gatherings strengthen peer support and morale. So we must remember that only clinical gatherings are not important. Even non-clinical gatherings are also important. Next, sir.
Well, also.
So last few slides, creative arts and reflection, engaging in painting, music, crafts. It helps us develop it. Basically, all these hobbies, they helps us develop, they ignite a different neural pathways and helps us developing cognitive behavior. So indulging in any type of hobbies is also very important. That may vary from person to person. And when we are indulging in community and shared joy, like hobbies with family or peer groups, again, this gives a feeling of belonging. It gives a feeling of bondness and togetherness. So indulging in group activities is also very important. Next, sir.
This is the last.
Last. Sir,
This is the
next.
last slide, sir.
Yes.
This is the last.
No, sir, there is one more slide. Okay, anyhow. So to end with, I would like to say that we must look beyond operators, and there are n number of medical and non-medical career opportunities, and not only professionally, but we must also look towards extracurricular activities to de-stress ourselves. So thank you so much.
Thank you, Dr. Kapil Singhal. So that was absolute great. What all things we should be doing. I feel in the meantime, by giving my comments, I feel Dr. Jay Lalwani, can you please start screen sharing? I've stopped screen sharing now. So when this topic was thought of, what I wanted to say, as Sir rightfully pointed out, the burnout syndrome, and we are absolutely high risk for having heart attacks and other complications. So I feel every day, maybe about 2 hours, or maybe at least one day of the week, we should forget that we are anesthesiologists and do something else, do some other routine activity, go out for family get-togethers, go out for picnics, have your uh, in a survey which I had done about 2 years back, I came to that hardly about 40% of the city branches have monthly meetings. We here in Nasik are so cohesive because we meet at least once a month and we have regular family get-togethers. These family get-togethers, believe me, are a very big thing. I mean, I remember when I was president about 10, 12 years back, I had organized a musical evening live orchestra. So that evening, some of the lady anesthesiologists had thanked me at the end of the show, saying that today our children begin to feel that we used to wonder what our father does. He just takes a bag and goes out for taking calls. But by having such sort of a get together, they realize that whatever their father is doing is something very great. So the esteem of the parents was raised by the children. And I know of at least 5 students from Nasik who thanked me for having such a get together. So please, please come out with such ideas in your own city and be more cohesive, and it increases the bonhomie, organizing conferences. I feel the cultural activities have really bring the families together. Good. I feel I can go on and talking on that. I feel, but happy that Dr. Lalwani could screen share. Madam, you can please go ahead. You have already been introduced, so please go ahead with your talk.
Thank you, sir. Thank you, sir, for the kind words of introduction. A very good evening, respected President Dr. Bala Venkat, sir, Vice President Dr. Viren Sharma, sir, all respected GC members, and thanks, Pankaj, sir, for giving me this opportunity and the ISA National Headquarters to speak before this August gathering. I will also take this opportunity to request all the participants to register for ISECON Raipur National Conference in November, if you have not done so. So, from suit to site, ensuring anesthesia vigilance beyond traditional boundaries. Change. Not able to move the next slide. Is my screen visible, sir? I'm not able to go ahead.
Yes, the screen is visible. In fact, the format that you have sent me also is a different format. That's why I cannot share.
Dr. Jaya, use the mouse pad instead of the figure keys. That might work. Use the main pad.
It's there. It's there. Now it's there.
Yeah, it would work.
So this is also known anesthesia beyond the traditional boundaries. There are also different names like non-operating room anesthesia, anesthesia at remote location, outpatient and office-based anesthesia, which is defined by the Royal College as a place where anesthesia is being given, whether it is general, regional, or sedation, beyond the normal operation room, and where the help of another anesthesiologist cannot be expected or guaranteed. So there is a 3-step paradigm for non-operating room anesthesia. One is the patient, most important. Second is the procedure, which the patient will be undergoing. And third, the environment where this procedure will be going. And in the center of the trial is the anesthesiologist, whose responsibility is to maintain a perfect balance between the three. So the first is the patient. He might be at the extremes of age, children, elderly, having higher ASA physical status because of the various comorbidities. He may have claustrophobia, anxiety disorders. So a thorough pre-anesthetic assessment, along with appropriate levels of monitoring, the ASA basic standards for pre-anesthesia and post-anesthesia care are required. A review of medical, surgical, anesthetic, and medication history is must, because we need to know what medications are to be continued on the day of surgery and what needs to be stopped. Physical examination, including the airway, intravenous access, and examination of the spine is a must. Don't hesitate to order the lab investigations which you think are necessary for that patient who will be undergoing that procedure. Assessment of ASA status, the NPO guidelines of the ASA or the ISA need to be followed. Informed consent is a must. If it is a child, please take the consent from the parents. Now, these are the tour destinations where your presence might be expected. The third factor, the environment. It should be as close to the main OT as possible when feasible. The ASA mandates the proper functioning of equipments like a reliable source of oxygen need to be present, along with backup of oxygen. That is a full E-cylinder type, E-type cylinder should be present. The suctions should be adequate and a reliable source. Sufficient electrical outlets. Illumination should be adequate. The anesthesia machine and monitoring equipment should be there. Don't expect Volkswagen, but ensure the ambassador is not leaking petrol. Meaning that don't crib over whatever is not being made available to you. The hospital ne ye nahi diya, wo nahi diya, but ensure that the ambassador is not leaking petrol. Means the whatever equipments you have, you should be conversant. You should check those equipments like the resuscitation equipment should be adequate. The emergency drugs, intravenous fluids, defibrillator, airway equipments be available. Monitoring including capnography, anesthesia machine as good as and equivalent to those which we are using in the main OT, appropriate post-anesthesia management, and a trained staff with whom reliable communication can be established, and a scavenging system if possible. Standard 1 monitoring that the presence of anesthesia personnel throughout the conduct of the procedure, a continuous display of the ECG, oxygenation, ventilation, circulation, and temperature needs continuous evaluation. Low concentration alarm for the inspired gas oxygen concentration, pulse oximetry, position of the tube to be verified clinically and by ETCO2, mechanical ventilation disconnection alarms with audible signal should be there, and NIBP should be monitored at a minimal interval of 5 minutes. These are the different levels of sedation and analgesia which have been defined. So there's a very narrow margin. So the balance has to be maintained, because easy drifting from a state of conscious sedation to a deeper level, depending on the age of the patient, his sensitivity to drugs, and the health status. Recognize the progressive blunting and loss of airway reflexes, along with the patency, together with depression of spontaneous ventilation, and emergency services need to be immediately available for the rescue of the patient. Coming to the radiological suite, specifically the MRI, there's a rigorous checklist for checking the presence of ferromagnetic implants in the patient, like the ICDs, the cardiac pacemakers. They may become a lethal projectile, and there is a lot of noise in the MRI suite, so ear protection is mandatory. You can use simple earplugs to reduce the impact of noise. Minimize the time spent in the scanner. The cables, wires wound in the loops, they cause the heating effect, so there may be thermal injury. Temperature monitoring is must in the children, and keep in mind that the electronic equipments and monitors, the infusion pumps, they will malfunction in the MRI suite. The patients may have claustrophobia, anxiety, so we can counsel them that we are available just outside this MRI or the scan room, and nowadays handheld bulbs or bells are available, so you can tell them that you can just press the bulb and we will be at your rescue. MRI compatible anesthesia machine is a must. The gas cylinders are made of aluminum. Routine vaporizers will not function. There are special ECG electrodes and cables available. MRI compatible equipment should also be checked. The laryngoscopes are made of plastic with aluminum covered lithium batteries. Copper stillets, routine endotracheal tubes can be used, but avoid the reinforced ones. And the defibrillator infusion pumps may malfunction or get damaged. There's a zone of inaccessibility around the patient's head, limited access to the airway. And also because these suits are made for the radiologist and not for the anesthesiologist. So there's difficulty to place the anesthesia machine also. Use extensions on the ventilator circuits, the intravenous lines and the oxygen tubings. Infusion pumps, blood warmers should be placed far away. And again, I'm stressing that good communication with the proceduralist is must so that we can monitor the progress of the case with him. The pre-procedural preparation is as routine, which I said previously. Most important for MRI is that the patient should be admitted in the hospital, because ये नहीं कि patient OPD से भेज दिया, it is a short procedure, 10 minute का CT है. No, if something goes wrong, then we will be in trouble. When sedation, when GA, if the child is more than 3 years, more than 10 kg, no comorbidities, you can consider sedation. Some may even sleep without drugs. When we are using contrast, be careful about the kidney function test. Idiosyncratic reactions may occur which are unrelated to the dose and concentration of the contrast admitted. So the treatment is oxygen, epinephrine, and bronchodilators. Pre-treatment of patients whom have contrast reaction previously with steroids and diphenhydramine are recommended. And there's a risk of contrast-induced nephropathy. So preventive measures should be taken, like adequate hydration, maintain good urine output, use of soda bicarb infusion, and avoidance of nephrotoxic medication for 24 to 48 hours before and after the use of IV contrast agents. Hypersensitivity reactions are common. Luckily, fatal ones are not so common, but the treatment, we should be prepared with the treatment. Discontinue the causative agents if you detect the hypersensitivity reactions, supportive therapy with oxygen, intubation if required, cardiovascular support with fluids and vasopressors, inotropes, and bronchodilators if required. Any emergency, if it arises in the MRI suite, stop the procedure and MRI machine immediately. Personnel going inside should check for the presence of ferromagnetic materials. And remember, take the patient out of the MRI and give the basic life support, because resuscitative equipments cannot be taken close to the magnet. Cryogenic gases, when available, can be used to dissipate the magnetic field, but they can create hypoxic environments. In the CT scan room, be careful with the airway management and adequate oxygenation of the patient if sedation is being used, because the patients are often inaccessible to us. Monitor the disconnection and kinking of tubes. If oral contrast is being given, there's a risk of aspiration. And there's a technique described, you can, for the neonates who are undergoing CT, feed, wrap, and scan. You can feed the baby, wrap him so that he's cozy, and then put him to scan, because he will sleep. Most of the time, these kiddos, they sleep, and nothing will be required, and the scan can be done safely. In the endoscopic suite, there are the problems of difficult airway access, shared airway, prone position of the patient, the table is non-tilting, the dark room, hemodynamic instability because of vagal responses. The elderly, most of the time, the patients are elderly with limited cardiovascular reserve. They might be dehydrated because of osmotic bowel preparation. Give care to the pressure areas, and extreme rotation of the neck should be avoided. There's a risk of aspiration because of the use of local anesthetic sprays and sedation. Those who are not appropriately nil by mouth or other GI pathologies would need endotracheal intubation. In the ERCP procedure, often these patients have comorbidities, the prone position. Avoid the drugs which affect the sphincter pressures, atropine, glucagon, and opioids. And by the use of antispasmodics, sinus tachycardia can occur. For interventional pulmonary procedures, preoperative review of common comorbidities, and muscle relaxants use is preferred to prevent coughing. The instrumentation of airway compromises the delivery of inhaled anesthetics and also pollutes the procedure room. Steroids during and after the treatment, they are not effective to reduce the edema because of the bronchoscopes. Aspiration is a potential risk, so be prepared for the management. High frequency jet ventilation is used, which is helpful because it gives the static fields. The patient procedure and position typically requires hyperextension of the neck. So be careful. They should be assessed for risk factors for an unstable cervical spine. and order a pre-procedural ABG if there's a history of significant hypoxemia or hypercarbia. In the interventional cardiology suite, these patients are at increased risk of arrhythmia, so the external defibrillator pad should be easily accessible. Use the arterial, radial, and CVP monitoring for high-risk patients, along with the standard monitoring. Transthoracic DC cardioversion is distressing, so sedation is preferable, except in life-threatening situations. A small bolus of IV induction may suffice. T is done prior to the procedure to determine the risk of thromboembolism. Now, what are the benefits of pediatric sedation only? It is easy to administer, lower cost and early discharge, but the disadvantages are the high incidence of failure. Airway complications may occur due to over-sedation, and there is unpredictable onset when we are using enteral sedatives, which may delay the schedule of the procedure, and then the proceduralists, they say that a lot of time has elapsed. So don't tempt to give the sedation enterally. Wait for the time for the onset of the drug. And remember this mnemonic, SOAP me, and be prepared with the suction, oxygen, airway, the pharmaceuticals, M is for monitoring, and E for equipments of resuscitation. Minimize the radiation exposure. So be careful and wear the properly fitting lead shielding. Use thyroid shields and lead glasses. Wear radiation badges that are monitored on monthly basis. And you can leave the room during specific imaging runs, especially in the DSA. For the endovascular treatment of cerebral aneurysm, complications like aneurysm rupture and thromboembolism may occur. So if it occurs, unfortunately, the heparin is reversed with protamine and blood pressure should be reduced. There's increased risk of bleeding with these procedures. So follow the ASTRA guidelines and about the use of anticoagulants. When is warfarin to be stopped? 5 to 7 days before the procedure. Clopidogrel and aspirin for 5 days. Fractionated heparin for 12 to 24 hours. And cerebral angiogram may proceed with anticoagulation on board. With these high-risk interventions, when there is increased risk of bleeding, send a sample to the blood bank and communicate prior to the intervention about the change of hemodynamics and initiation of blood pressure support. Cardiac catheterization lab. Again, there's increased risk of arrhythmias, so accessibility of external defibrillators should be ensured. Cross-match blood products be available in anticipation of complication. Patient positioning often requires patient hands to be above the chest, which predisposes the patient to the risk of brachial plexus injury. And patients with congenital heart disease often have associated anatomical anomalies, including a difficult airway. So care be made about this. In the electrophysiology lab, atrial flutter ablations require the arrhythmias to be suppressed under GA. So these procedures will require sedation, but because these procedures are very long, maybe up to 4 to 6 hours, followed by the observation time. So it is very challenging to conduct them with MAC, and they may require GA. High frequency jet ventilation reduces the thoracic movement due to the tidal ventilation, but again requires monitoring with ABG or ETCO2. Hypercarbia refractory to adjustment in jet ventilation may require transition back again to the traditional ventilation. And there is unpredictable delivery of the volatile anesthetic with high frequency jet ventilation. So TIVA may be necessary for the conduct of these cases. The concerns are that paralysis is to be avoided. Remifentanil infusions, when available, can be used. Temperature monitoring is mandatory. Esophageal temperature probe, correct position can be verified with the use of fluoroscopy. Care should be given about maintaining the proper fluid balance because radiofrequency ablation requires irrigation with substantial amounts of fluids over the conduct of the case. So assess the fluid balance and consider the administration of diuretics. Preoperative evaluation for patients undergoing ECT about the current medication history. They may be using antidepressant medications. And post-ECT, look for proper oxygenation of the patient, place him in the recovery position, should be monitored till discharge criteria are met. Then record the patient's condition, the responses, and extra precautions during subsequent treatments. Most important is documentation of anesthesia during the conduct of these procedures outside of the routine operation room. So a time-based anesthesia flow sheet should be maintained. A mention to be made of the level of sedation given, the drugs, when they were administered, the time and date. If there is minimal sedation in short procedures like CT, the monitoring can be omitted, but observations at every 15 minutes if conscious sedation is given, and the recordings at every 5 minutes if you are giving deep sedation or general anesthesia. A word about the recovery and the discharge criteria after NORA. Each anesthetizing location should develop recovery and discharge protocols which are appropriate for the specific patients and the procedures conducted. The discharge criteria are no different from those which we are used in the main post-anesthesia care unit. A proper documentation, because it is a medical legal document. So documentation has to be made about the patient's discharge, that the patient's discharge criteria were met when he was discharged. And patients have also to be informed that home readiness does not mean that he can drive a car back home and he can immediately return back to work. So the take-home message is that the anesthesia professionals need to continue to define safe practices, establish appropriate guidelines, direct efficient resource management, and establish a risk-related data. To provide efficient and safe non-operating room anesthesia, preoperatively assess the patients, monitor the patients during and after the procedures till they are discharged, provide targeted anesthetics for a multitude of increasingly complex cases.
Thank you. Thank you, madam. Are you done?
Yes, sir.
Okay. Thank you. Thank you. Thank you, madam. That was a very exhaustive coverage of the topic. It's very difficult today to manage many of these cases outside the operation theater. We all know being captains of the ship in the operation theater becomes very easy. But when you get a call in, especially in private, and you're asked to give anesthesia in an MRA suit or a CT scan suit, believe me, things are not very rosy there because the basic standards are not maintained, especially in individual setups. In corporate setups, probably now people are getting proper monitoring equipment and all the proper equipments are available. But there have been some cases, especially in dental anesthesia cases, that a sedation or a short J was given in the dental chair, or and there was no proper ICU backup. So such cases have gone against the anesthesiologist for giving anesthesia in such situations. So I feel just a word of caution to all those who are giving anesthesia in individual setups. See that you have a proper ICU backup, because a lot of cases have gone against the anesthesiologist just for not being taking proper care.
Sir, they
Actually,
will
we had a
invest.
very nice.
They will invest lakhs of rupees to get the MRI, but they will hardly spend any amounts to even make available the oxygen cylinder or the basic boils.
Exactly. That's why a word of caution to everyone in private, especially. Please be careful when you are asked to give anesthesia in such setups. Even I have gone through that phase, but it's very difficult in case you have had a problem there. Thank you. Thank you. I feel we have had a wonderful discussion by all four speakers. And I'm sure there'll be a lot of questions and people would like to can just raise their hands and ask directly. Someone has asked one part. Which drug is to be avoided in pre-medication for which drug is to be avoided in pre-medication for ERCP? Dr. Mohan Patak. Dr. Lalwani, madam.
That atropine glyco, they increase the intrasphincter pressure.
Yeah.
Opioids.
Yes. Also, along with that, I would just like to add, when you're doing silent endoscopy, never give atropine or pyrrolate to this patient because the surgeon finds it very difficult to find the punctum. He's not able to put in his scope. I do a lot of silent endoscopy,
Yeah.
so I just
Okay.
remembered this. Yeah.
Okay.
Any more questions? One question, if I would like to ask Dr. Kiran definitely. You are in the operation theater. The surgeon has become very abusive. I faced this. He starts throwing his instruments and throws a fit. What should be our modus operandi? How should we manage to manage the atmosphere in the OT, and how to talk to the surgeon during or after the surgery? Your comments, please.
Yes. Uh, Thank you, sir. Sir, see, when a surgeon is aggravated and you have got the ringside view, sometimes it could be simple infrastructure issues. You know, he doesn't have an assistant who's there. He's got a technically difficult case and he's waiting. So there are at worst. And it's almost like when they do this conflict resolution, they say in that heat of the moment, it's like trying to reason with an alcoholic, you know. So you have to wait there. So you try to mitigate the circumstances which are less hostile for the people. So you can gently intervene, you know, like if there is a particular agreement point, कि वो वाकई कैंची काम नहीं कर रही है, and now he's got a bleeder which he can't control. So you can make sure your anesthesia conditions that we are applying at that time, your pressures are not 200 by 110, which are adding on to his problems. So try to make sure prima facie that you are giving great anesthesia, which is not adding to the surgeon's problem. And even as a role model, so like we are very fortunate, we have Dr. Bala Venkat. He's an exceptional mentor. You know, you see how he conducts himself. And respect is mutual, sir. I'm very fortunate that very rarely any surgeon has been abusive to me. Yes, in stressful condition, they tend to take it out on the staff first rather than taking out on you, you know. So it's equally important to understand, because what I would do if a young surgeon who has come in there, who has been not exhibiting the best behavior, try to make his life as easy as I can during the surgery, handle whatever he needs, get his logistics, all other. But once that is done, a one-on-one dialogue with him and describing the day to him, you know, like today, sir, I think what we could have done. And once you start screaming at your juniors, they tend to make more mistakes. They're not going to be better assistant to you. If you yell at an anesthesiologist, he's not going to make your life easy to you. So generally, you need to have one-on-one dialogue, which could be in the OT. It could be in a less hostile environment where you can be, you know, at a home or at a club or at somewhere else, where you do illustrate that point, your behavior. They didn't have a situational awareness that how you could have handled it better. Sometimes it could be a very senior Dian who is like the god of the OT and nobody dares question his authority. Whatever he says, he brings lot of revenue to the institute when they're almost the untouchables. So if you are a junior in a position where you are facing a god in an OT, yes, you stay calm, you're respectful. You can tell at the end of the surgery, like that behavior was setting up. At that heat of the moment, getting into a conflict when surgery is going on doesn't help. So choose the timing, but it's important to have that conversation. If he's a persistent defaulter who keeps doing this is his default mode of operating, this is what he has learned as maladaptive, you probably need to enlist the help of a senior who that person listens to, that this is a behavior that is affecting him as much as it is affecting us. It is about having very awkward, uncomfortable conversations, but unless we have them and set clear boundaries, like this is not. And fortunately, in 20 years, so there has been a shift change. I grew up in got trained in very competitive institutes where there were mega personalities, and some of them exhibited these behaviors. But coming down 20 years around, most of the surgeons are pretty congenial and pleasant. Most, as is the word. And as I said, we are working in stressful environment. We are not aware. Just talk to them. But if they are still doing there, as you rightly said, if sometimes it is a behavior which is affecting you to that degree, this is a person who with repeated talk and behavior, then you change your working environment in worst case scenario, in the worst case scenario. Yes.
You know, during your talk, I was reminded of two instances where the assistant was scolded by the surgeon continuously during the whole surgery. And at the end of it, he literally fainted and fell down. One of the assistants, I remember I had to literally give atropine because I could not feel his pulse.
Yes.
Fortunately, I immediately, you know, these sort of things do happen. And of course, when the surgeon is in that heated moment, we cannot tell him anything. But definitely, I feel at the end of the surgery, you should sit down one-to-one with the surgeon and discuss it out with him. Please don't, please stop this behavior in the operation theater.
And
Because if
it's
he can be so
important
abusive,
to raise the raise it to the administration also, sir. Raise it to the
Yes.
other teams also, that behavior is not to be encouraged. It's important to put our foot down on bad behavior. And
Yes.
this is apparent yelling, sir. Even that cold treatment, malicious, there are so many sub-layers of bad behaviors which can destroy the core of a person, sir.
Yes.
When somebody can be rude to you without apparently yelling at you, who can be late for reporting to work, he may be ignoring your services, he may not be paying your remunerations. There are so many other ways the surgeons could be disrespectful to you as a professional. There also it is important to lay your boundaries, but respectfully, sir. And generally, if you command respect, they would give it back. But at the bottom line, sir, onus is also on us to be professional, reach in time, behave nicely to our staff, train our staff who are not trained, understand the training needs of the people we are working with, and also have great skill sets. If you are great as an anesthesiologist, most of the surgeons would be extremely respectful to you.
Dr. Kamlakar Pawar has asked a question. I feel Dr. Jai has already answered it. Would you like to talk about it, Dr. Jai?
Yes, sir. Many a times we think that can we give prophylactic medications to prevent the reaction, but the literature does not support the use of these drugs except for to be vigilant, monitor the hemodynamics, and if any time you feel that it is the hemodynamics are changing and the reaction has occurred, then only you can give the drugs. Prophylactically administering the drugs will not abort the reaction.
Dr. Mohan Pathak has suggested that MRI compatible machine should be made compulsory for MRI centers. Yes, but
Sir.
unfortunately, that is not happening in most of the centers in the
Yes,
country.
sir.
Actually,
I
Dr.
can see
Pankaj,
Dr.
I'll add to
Rashish.
this. If you see those who install this MRI machine, if you tell them they arrange for it, they don't charge you extra. The only question is whether we ask them to arrange or not. It hardly
सर
costs
बट
them
बोलने
anything.
से होता नहीं है ऐसा अपन बोलते हैं लेकिन दे डोंट वांट टू स्पेंड दैट्स व्हाट माय
No,
एक्सपीरियंस
it's
दे डोंट
not
वांट टू
a.
स्पेंड द एक्स्ट्रा penny सर.
I'll tell you, madam. Actually, in our place when this was installed, so it was told to the company because they know that this is a requirement. See, all companies which install MRI, they know at many places they have to arrange this MRI compatible machine. It's not easily available here and there. So
Yes,
if you tell them 99%, they don't charge anything extra because
okay,
if you compare the cost of the MRI machine
yeah,
and
that's
this
what I
machine
said.
hardly cost anything. The only thing is, as an anesthesiologist, if we stress down that look, it will be a problem if we don't have machine. Those who are going to, the problem is with the private centers. See, they order MRI first. They don't have a regular anesthesiologist. They call on the basis of availability. Then this problem or issue comes.
Dr. Rashish Diwan, I can see online. Dr. Chauba is there among the National GC members. Can you unmute yourself and make your comments or suggestions on the topics? Dr. Rashish Diwan, I can see you online. Or anyone else would like to unmute themselves and give their comments or suggestions? Dr. Sri has asked if all the PPTs and recordings can be circulated to all the city branches so that they can be played multiple times. All webinars are recorded on YouTube, and you just have to go to ISA NHQ, and you'll find all the webinars of ISA there in the. So you can anytime, even after the webinar is over, you can open them and see them anytime. Anyone would like to make any comments or
Sir,
suggestions?
I would like to just say one thing about sedation in the remote locations. That time are gone that we as anesthesiologists, we are no more beggars. We must come out of that attitude that we are begging something. You cannot ask any of your surgeon to do suturing with the help of reusable sutures or no, they cannot. You cannot tell them not to use staplers. So we have to come out of that mindset. And as
Yes.
Dr. Virendra Sharma sir said, that most of the MRI installation companies, they will provide monitors along with them. And we as an anesthesiologist, it's our just full duty to ask for at least minimum monitoring things before giving any amount of sedation to any patients. Because if something goes wrong, none of the administration or clinic holders, owners or hospital owners, they are not going to come to our rescues. It is we who have to face the consequences. So we as anesthesiologists, we have to put our foot down that see this is the minimum monitoring requirement which I am going to need. Otherwise, no, I am not going to come. And if all of us decide in the similar way, they will not find a single anesthesiologist. That is the key message.
Absolutely. That's why the unity in every city is very important. What one does it, everyone else should be doing it. Unfortunately, in some cities, smaller cities, what happens is someone says no. The third person takes it like an opportunity and says yes for that particular thing. And unfortunately, there is a complication. He has to face the music. So I feel it's very important to be united. Dr. Pathak has raised his hands. Dr. Pathak, please. Dr. Mohan Pathak. Yeah, please. You can unmute yourself, Dr. Pathak. Dr. Pathak, please. Please unmute yourself.
He is
Dr.
unmuted,
Naresh,
but you can't see him.
can't hear him. Dr. Naresh Paliwal has made a suggestion that radiologists should not get a license to install MRI machine without this MRI compatible anesthesia machines. Unfortunately, as anesthesiologists, we don't really have a say. But yes,
No, sir,
definitely it's for us to
seriously,
put our foot down.
these days they don't sell motorcycles without the helmet. So I think it is a statutory things. If we are
Okay, good.
getting an MRI, you need to have an MRI
Yeah,
compatible.
actually,
And we need to stick our ground. We really need to stick our
Yes.
ground. And as collaborative society, put our foot down. That's bare minimal anesthesia monitoring standard one.
That
But
is where the
sir,
city branch is very important. The unity in the city branch is
yes,
very, very
unity.
vital. If you want to get anything done in that particular city, see, when we are discussing remuneration, Virendra and me have discussed with so many cities in the country, and every city works different. So till you are not united and come together, your city will not prosper. Today in Nasik, we could do everything because we are united. Dr. Pathak, I feel now is on the line. Please, Dr. Pathak.
Sir, I have given a anesthesia for MRI at least 5 centers where there were no facilities, even big corporate hospitals. So, and there was one day a big politician in the MRI center few years back. So the company should make it compulsory, like while selling the scooter, they give they have made a helmet is compulsory like that. So anesthesia facilities are not very costly affair. So they can make compulsory because we are alone there, nobody is here, remote place and without any facility. So only few of the centers have got MRI compatible machines nowadays.
It's a good
Okay.
suggestion, sir, because I feel in the next GC meeting, we can put forward this question. Dr. Bala Venkat is not there, but I'm sure Dr. Virendra is there. So we'll definitely put it in the question, in the meeting that it's a good idea to sell monitors along with the MRI machines, or don't sell the monitors. I
So
feel someone has made a
radiology collaboration with the radiology society and put them across because they are the
Yes.
one who need. So if ISA can talk to
yes,
the radiology society as a blanket, this thing, when you're buying this, buying a monitor is mandatory with that.
yes. Okay,
Actually,
Indrani is
there
also
is one
met.
more
Dr.
issue,
Indrani.
Dr. Pankaj,
Uh,
one more issue, ma'am, Dr. Kiran. The issue is there are many businessmen who are establishing diagnostic centers. Now they do not understand the value of all these machines and all.
That's right.
What they do is they order MRI and all these things. See, if at the city level, even if we approach that center and tell them that please arrange this machine, otherwise you will be in problem, we will be in problem. I think, see, it hardly cost as compared to the cost of the machine, it is negligible. How much it cost? So
So
it's
2 lakh
not that
rupees for MR compatible monitor, 2 lakh rupees, that's it.
2 lakhs.
everyone will arrange. The thing is, if Dr. Kapil says no, I will not come here, Dr. Jayam may go. So that is the issue. We compromise on ourselves. If at the city branch level, on the city letterhead, see, why to ask for national association to write to them? When our national secretary has already issued instructions to city branch officials for monetary thing, this can also go on a city letterhead of ISA, which
Yes.
names these centers would be knowing. So if we just communicate to them that, look, it is disastrous to give even sedation in MRI suite without having a machine, we request you kindly arrange for a MRI compatible machine. I'm sure they will listen to it. I'm sure.
Yeah. Dr. Indrani, I can see. Dr. Diwan, yes, sir.
Yeah, thank you, Dr. Pankaj. And it was a really very good webinar, and more useful was the discussion at the end of all the lectures. The lecture presentations were excellent. But like this, we have PNDT Act where you have to put a board. So the, if we implement that this MRI is not compatible for doing sedation and anesthesia. Like that kind of law, if is implemented, no, they all businessmen will do it. They always fear the law. But guidelines are not laws, actually. Guidelines, we believe we should follow it. And guidelines are there, but nobody follows them. And more important point which was raised by you was the unity. Because our own colleagues, no, nothing happens. It's not a very high risk case. I can give sedation. So that should be, we should have a unity and not doing it unless we are fully satisfied with the facilities. I had been a private practitioner for almost 40 years now, gave up the practice recently. And because of the stringent guidelines, which are absolutely mandatory, and because of the guidelines, we make the rules, it is becoming very difficult to do the private practice, even for the surgical colleagues. There's a reason we are turning into corporate culture now. And even in the corporate cultures, semi-corporate hospitals, it is very difficult to implement these rules. So it is we have to unite and implement it, because ultimately it comes to us only.
What happens?
Dr. Indrani?
The seniors many a time refuse, but the juniors, the freshers,
That's right. That happens.
just MD pass outs who are there, they will go and they will do the heroic step and they'll give sedation. This is what I've personally
That's what
experienced.
we want to stop at the city level, because it really can be very dangerous. Dr. Indrani Hemant Kumar, you have made some comment. Are you still there?
Then you realize it's at very high cost.
Dr.
Yes.
Mohan Pathak wants to speak again. Yeah, Dr. Mohan. Please unmute yourself.
On the contrary, juniors are more demanding. They don't give anesthesia in the remote places and where facilities available.
Juniors, I've seen are very up regarding remuneration. About this, I'm not aware. But I've seen
Yes,
that they are both stringent about what we were when we started practice.
Yeah,
We had a wonderful
Indrani has come.
discussion.
they don't
Indrani
adjust
has
the.
Pankaj, Dr. Indrani has
Yes. Yes, madam. Good to see you.
Yeah, see, that is what I have put in a comment that I've heard of innumerable stories of anesthesiologists leaving patients deeply sedated in the MRI suite, actually. And most number of critical events which have occurred, just patient barely, survived or patient died, those things are because of anesthesiologists.
Yes.
And the next important thing, I completely agree with Dr. Naresh Paliwal when he said that nobody should be allowed to buy MRI without MRI compatible equipments. But what is more simpler is also, till such time we achieve this, every MRI suit should have naloxone, flumazenil with them. Why they don't have it? That's a standby answer to it, right? If patients are deeply sedated, then we have drugs which can, reverse these agents. Here, there is no question of analgesia, right? It's only sedation. So we can completely reverse it. So I think, every MRI suit should at least have reversal agents with them.
True.
Absolutely. That's what as Dr. Virendra Sharma rightly mentioned. Every city now should come out with proper guidelines and instruct their MRI or CT scan centers to have the minimum requirements.
So,
Definitely
no,
a
what I'm
good.
trying to say is just that, because this webinar is emphasizing safety. So,
Exactly.
safety, this is one of the most essential thing which every MRI suit or any NORA suit for that matter, wherever sedation is being given, even if it is a dental, suit. So I feel, we should have reversal agents and we should insist that every suit should have these reversal agent.
Thank you, madam. Anyone else would like to speak, or should we call it a day? We've had a wonderful discussion, I feel, on everything. Anyone else? Great. I feel we can call it a day. I feel we'll conclude by I should really thank all the four speakers from the bottom of my heart for really coming out with wonderful presentations, and the discussion was great. It was very nice of Dr. Virendra Sharma to be with us right till the very end. Dr. Balavenkat, in spite of being so busy, he always tries to be there for all our webinars. Really thankful and in-depth to him. All my national GC colleagues have always been stood by me in whatever discussions and decisions we have been taking in the GC. I really thank each and everyone, and of course, the private practitioners in the country. I feel I'm getting more and more suggestion that this thing should be made available. It is available. Anyone can see it later on also. I will share the link in the PPF groups. So you can forward it into all your city groups, and whatever they have missed out, probably they can have a look at the webinars. And all webinars are available on ISA NHQ. Thank you. Thanks a lot, each and every one of you who have been
Thank
there
you,
right
sir.
till the very end.
Thank
Good
you,
day.
sir.
Good night.
Thank
Good night.
sir.
Good night, everyone.
Good night,
Good night.
everyone.
Good night,
Thank you, sir.
everyone.
Thank you.
Thank
Thank
you.
you, Virendra sir. Thank
Thank
you,
you.
Pankaj.
Good night.
Good
Thank
night
you,
and
everyone.
thank you, sir.
Good night. Wonderful. Divya, Jaya, Kiran,
Thank you, sir.
very nicely,
Thank
very
you, sir.
nicely done.
Thank
And
you,
in
sir.
fact, I should really thank Dr. Kapil. Actually, his father has not been well since yesterday, but he sent me the presentation. In case I'm unable to do it, you please do it. I feel we had wonderful discussion, and thanks a lot from the bottom of my heart.
Thank you, sir.
Sir,
Thank you,
thank
sir,
you
for
for
giving the
having
opportunity.
us.
Thank you for
Thank you
having
for
us.
the opportunity and excellent flow, sir. You conducted it so nicely.